Growing Older, New Challenges, New Needs. These professional development webinars, which are presented in conjunction with RRTI and the Lewin Group, social workers, counselors, registered nurses, and other healthcare professionals, are supported through the Medicare-Medicaid Coordination Office, or MMCO, in the Centers for Medicare-Medicaid Services, or CMS, to ensure beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes a full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare-Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar series. To learn more about current efforts and resources, please visit Resources for Integrated Care at www.resourcesforintegratedcare.com. Just a little housekeeping before we get started. Your microphones will be muted throughout the presentation. However, there will be a question and answer portions during this webinar. So if you do have a question, please click the Raise Hand feature on your control panel at the designated time, and you'll be unmuted by an administrator. You can also type your questions into the chat window, and an administrator will ask the question out loud during that designated time. There will also be poll questions throughout the presentation. A window will appear with the questions, and you can submit your answers at that time. At the conclusion of the webinar, a tab will appear in your browser prompting you to complete the evaluation survey. It is required that you complete this evaluation survey in order to receive 3 contact hours each from the Michigan Social Work Continuing Education Collaborative, New Hampshire Nurses Association, National Association of Social Workers. If you are unable to complete the survey at the end of the webinar, you'll receive an email tomorrow with a link to complete the survey at that time, if you have not already done so. So at this time, I'd like to introduce our instructors to you. Jill Dorsey is a licensed clinical social worker who's a mental health program specialist for New York State Office of Mental Health. Ms. Dorsey has over 30 years' experience working with individuals with mental illness and developmental disabilities, including supervision of 5 nurses providing care to over 200 individuals above age 60 in community-based family residences. She is also trained in person-centered planning, cultural competence, and recovery-focused practices. Linda Anderson is a registered nurse screener for HealthQuest Thompson House, where she meets and reviews patients in all area hospitals as potential rehab candidates in subacute rehab, and is PRI and screener certified. She was previously employed as a CMNH at Taconic DDSO for 20 years in the family care unit and 15 years at Helen Hayes Hospital in acute rehab. Ms. Anderson is also a member of the bereavement committee at Taconic DDSO and a Prader-Willi educator, as well as a participant in IBR study on Fragile X and Down syndrome and Alzheimer's disease. Now let's begin.
Okay. Hello, everybody. I'm Jill Dorsey, and it's really exciting to be here today and to have this opportunity to present with Linda Anderson. As you just heard, Linda and I both have probably about 50 years experience between us. And we did spend a lot of that time working together in a program called Family Care, in which people with developmental disabilities lived with family caregivers. Most of them were over 60. Some of them were as old as 90. So it was very challenging. It was very exciting. What was really good about it was that I, as a social worker, had the opportunity to work with Linda, a nurse, and we learned ways to collaborate and to blend our 2 practices. So the learning objectives for today, you're going to become familiar with the common physical, cognitive, and behavior changes of aging across all populations. So that would be not just people with developmental disabilities. We're also going to talk a little bit about how aging affects people in general. Examine how aging processes may manifest differently in people with intellectual and developmental disabilities. And we're going to be using that acronym IDDD. We're going to explore how past medical interventions, including the use of psychotropic medications, can contribute to age-related and behavioral issues for people with IDDD. We're going to also become familiar with the aging challenges that are specifically relevant to people with various syndromes: Down syndrome, seizure disorders, Fragile X syndrome, and the autism spectrum disorders. We're also going to consider aging supports and services within the context of person-centeredness, self-determination, and personal autonomy. We're not advancing, Lisa.
We'll be right with you. A little glitch.
A glitch here. So I think, as Lisa mentioned earlier, you can also be putting in questions as we go, and Lisa will be picking them up. And at the end of each section, we're going to take the time to answer those. Okay, so aging happens to everyone. It's a natural process. It can't be avoided or reversed. As my dad used to say, getting older is really difficult, but when I consider the alternative, it's okay. So we don't think of aging as something that we can cure. We don't think of it as something that we can avoid, but we do think about how we can manage it in a constructive way. If we want to age well, we know that this will be, to some extent, related to how we live our lives if we have good health practices. Our lifestyle can affect how our bodies go forward in life and how they respond to aging. Aging is a great equalizer. What Linda and I discovered in our work is that many times people with developmental disabilities, as they aged, really developed the same needs that people in the normal population did. But even so, people with lifelong disabilities often have age-related issues that are the result of the syndromes that they have, their lifelong disability, also to the medical treatments that they may have experienced.
Aging can be classified in many different ways. Primary aging is normal aging, a disease-free life across the lifespan. Good health practices that contribute to having a disease-free life across your lifespan. Secondary aging, changes with poor health habits, disease processes affect your lifespan in not so positive ways. Tertiary aging is a rapid loss of function. It's end-of-life aging.
Okay, so how does aging change us? Well, we look different. Changes are subtle at first, and we can conceal them with makeup. Our hairdresser becomes our best friend. But even so, it becomes harder to lose weight. It's easier to gain it. We lose some muscle mass. Cognitively, we start to think more slowly. It takes longer to learn new things. If you think about it, you know, people often make jokes about senior moments. The upside is, of course, that we have the benefits of lived experience, and we're getting older and wiser. Socially, we may lose friends. They may move away. They may retire and move to the south. People may pass on, and that creates isolation and depression, which also contributes to many health issues. Physically, we become more prone to injuries. Our vision declines. Our hearing is limited. And these can be addressed and managed, but they can't be changed. We can, however, age gracefully. You can minimize the effects by being proactive. With good health practices, you get enough exercise, you eat well, you work at staying fit. These are all things that are helpful. It's important to try to learn new things, to try to learn to play a new instrument, to learn a new language. These actually stimulate your mind and they keep you bright and alert and engaged. And staying socially involved is very important. You know, being in relationships that are nurturing and helpful.
There are some tools to help you age gracefully. These are just concrete suggestions to support aging gracefully. Things like eat a balanced diet, take vitamin supplements, maintain a healthy weight, exercise regularly. You know, take that walk down the driveway every day after work. Use your exercise bike you have at home, join a gym, but it's routine and it's regular. Manage the stress, have time for yourself, time to take a breather at the end of a work day. No smoking, avoid alcohol in excess. Continue your education, continue learning, continue looking at new things, exploring new things. Don't get stagnant. Maintain your social contacts and nurturing relationships. There are some factors that can't be changed that affect aging. Your age is going to happen no matter what. We all age. Gender can affect your aging process. Genetics have an impact on how we age. Ethnicity also has an impact on how we age. But individuals with ID and DD encounter additional factors that also can't be changed, complications of their disability.
And we're going to be talking about those in much greater depth in a little while. So for people with developmental disabilities, the concerns associated with aging become more complex for a number of reasons, but perhaps most significantly because of other people's preconceived ideas about people with ID and DD in particular, and aging in general. So we've all heard about ageism, and Linda and I have also experienced that many times people discount the abilities of someone with ID-DD, and they sort of dismiss what they're seeing as being related completely to the developmental or the intellectual disability. So when we consider providing supports to people with ID and DD, it becomes important to focus on these broad areas, assuring that the activities available to them are able to sustain, that they're able to sustain their level of function without increasing risks. We want to assure their continued community connections because that's important to health. Physical as well as mental health, and we want to help preserve their autonomy and their ability to make informed choices for themselves. So we want to preserve their personhood. So Linda, do you want to give an idea of the definition of intellectual and developmental disability?
An intellectual limitation that hinders independent functioning in daily activities such as self-care, communications, work, education. It's a disability that developed before the age of 22 that was documented in your health assessments and results in a need for long-term care and adaptive and functional supports.
And this particular definition, as you can see from the source on the slide, came from My Thinker's Not Working, which is a booklet put out by the National Task Group on Intellectual Disabilities and Dementia Practices. It's provided in the resources for this PowerPoint, and it's really a helpful and very, very rich source of information on people with developmental disabilities who are aging. It has a specific focus on Down syndrome, but I think it's applicable to many other people with developmental disabilities and IDA as well. So why is it so important for us right now to be considering people who are aging and who also have intellectual and developmental disabilities? Right now, there are people who have who are living much longer than they used to. In 2000, there were 641,000 people with ID and DD above the age of 60, and that was 14 years ago. The life expectancy for people with developmental disabilities and intellectual disabilities has increased significantly. In 1930, for example, a person who had Down syndrome was expected to live about 9 years. Now, an average life expectancy is 60. And the people with other etiologies of ID and DD are also living longer. At one time, they would live about 20 years, and now they're living, the average age is now 72. So as a result of the increased life expectancy, we're encountering new challenges and new needs for people with intellectual and developmental disabilities. As people with ID and DD age, they're going to need more sophisticated, enhanced supports than they do currently. And we have to ask ourselves, are we prepared for these? Another issue is that their caretakers are growing older. 75% of people with intellectual disabilities live at home with family members. So as the baby boomers age, the children that they are caring for, who are now adults, are also aging. So that creates a greater need for residential support. There's also an increased issue of dementia, particularly for people with Down syndrome. It's estimated that 54,000 people will be affected with mild cognitive impairment, which is the early stage of dementia, by 2010. And as a result of this, we're going to need to be looking at residential supports that are barrier-free, that provide more nursing oversight, more access to community services with physicians, occupational therapists, and physical therapists. So, are there any questions? Okay, Lisa's going to be reading those to us in a moment. Are there any questions, Lisa?
No questions.
Okay, we'll go on. So the way people with ID and DD experience aging is often associated with the genetics and pre-existing challenges that are related to the lifelong disability. We're going to consider these issues so that we're aware of specific risk issues that are associated with these so that we can identify and develop supports. So Linda had talked earlier about things that could not be changed, genetics in particular. These are some of the situations that cannot be changed in aging: Down syndrome, seizure disorders, autism spectrum disorders, Fragile X syndrome, Prader-Willi syndrome. There are additional syndromes that are often affecting people with ID-DD, but these are the most common, and these are the ones that we're going to be focusing on for the purposes of this presentation. So Down syndrome is the most common chromosomal abnormality that leads to an intellectual disability. For example, people with Prader-Willi often do not have any intellectual disability at all. People with Fragile X may have a mild intellectual disability. People with Down syndrome almost always have an intellectual disability. And this is related to a chromosomal abnormality, which Linda is going to explain.
Okay, there are 3 different genotypes and it's an important thing to know which genotype in Down syndrome, because free trisomy means there are 3 copies of the 21st chromosome. Trisomy also seems to be connected to more cardiac anomalies, valve disorders at birth. It's a good thing to know because then you're aware that there could be cardiac anomalies connected to that particular genotype. The other genotype that you look at is mosaic. Mosaic Down syndrome means there are some cells that have the abnormality and some cells do not have the abnormality. And translocation Down syndrome is a duplication of the 21st chromosome. People with Down syndrome tend to have an atypical lifespan in development because of anatomic disabilities, cardiac-related, immunologic disorders, neurological disorders, endocrine and metabolic disorders. That's why we're monitoring for thyroid function, we're monitoring for B12 levels, folate levels. These are all things that you're going to see changes in with someone with Down syndrome. And not consistently across everyone, but there are things we need to test for. Another anomaly that we test for in Down syndrome is cervical subluxation, where if you screen for that, you can prevent or be aware that someone needs to watch their activity levels
with that particular disability, or they could have subluxing of the cervical spine, which can lead to paralysis. So it's recommended that we do an annual cervical screen. And mortality risk for people with Down syndrome are higher. At younger ages. Dementias occur as early as 35 and 40. You possibly could, if someone is prone to a dementia, to start to see those kinds of changes. So we really need to keep good baselines so that we know what this person was like before dementia developed.
So as Linda said, people with Down syndrome have multiple physical and neurological disabilities as a result of their genetic abnormality. So it's important for us to be aware of these so that we can make healthcare providers in the community also aware of the intricacies of working with someone with Down syndrome. I think a good example, Linda had mentioned atlanto subluxation, axial atlanto subluxation. I'm still learning from her as the nurse. But in our practice together, we often had to bring that to the attention of regular general practitioners and internists and request that they be evaluated for this because it was not generally known. Another issue to be aware of when you're working with someone with Down syndrome is that dementia may start with someone at an early age, as Linda said, as early as 35 or 40, and it may be very subtle. What you may see is that the person isn't communicating as well, or the person is withdrawing, or there may be behavioral issues where there didn't used to be any. So it's important to screen for dementia beginning when the person is between 30 and 35, because as Linda mentioned, we want to get a really good baseline, which means we want to know who the person was before they started experiencing some of the deficits associated with dementia or with aging.
And that baseline needs to be documented and passed down from caretaker to caretaker so people are aware of who this person was prior to dementia, so that you have something to compare to, because what you're going to see in someone with Down syndrome before you see memory loss, you're going to see behavior changes. And you're not going to know, unless you have documentation showing what that person was like, you're not going to notice those behavior changes quickly enough.
And if you recall, we mentioned earlier that one of the issues we're coping with the aging ID-DD population is that their caregivers are also aging. So it's very likely that you'll be working with someone who's in a completely new residential situation. And having that baseline is going to be particularly useful for the caregiver who's beginning to know who that person is.
Some other complications of aging in people with Down syndrome are incontinence may be related to renal involvement, also may be related to an ADL change because of developing dementia. You need to assess what is causing that problem. If this person was never incontinent before, is it a renal change? Is it because this person is developing a dementia? We also, like I said before, we screen for hypothyroidism, B12 deficiencies, and those are all very treatable things with the medication. But you need to know about them. Sleep disturbances can be an indication of depression. They can also be an indication of sensory losses or changes that this person doesn't understand. As you age, vision changes, hearing changes. Are you seeing ADL skill changes because of that, or are you seeing ADL skill changes because of dementia?
Well, I think what you're saying is that when you're working with somebody with Down syndrome, I think to the greatest extent, and with the other disabilities as well, it's almost like you're on. It's almost like a detective story. You're really having to look at the person as a whole entity, and you need to kind of tease out where the disabilities are, where that person may be beginning to age and experiencing some deficits. And you need to rule out, one, is it renal involvement, is it dementia? Is this person withdrawing because they're depressed because they changed their home, or is there really something going on where they're feeling that they can't cope with the daily challenges of life? So Fragile X syndrome. This is a genetic condition which affects the X chromosome, and it's much more frequent in boys. Males have two X, or they have one X chromosome and one Y chromosome. Women have two X's. So if the X chromosome for a male is damaged, you're going to see the results of that much more readily than you would if a woman had a damage on one X, because the other X would function normally. As a result, I guess women, you were saying women are carriers frequently without even knowing it. So as a result of that deficit on the X chromosome, people with Fragile X frequently have different protein levels for brain growth, and this may result in some intellectual disabilities. Their behaviors are often affected. They may be impulsive, hyperactive. Sometimes people with Fragile X syndrome are misdiagnosed as being autistic or having an autism spectrum disorder because there are some behaviors that are very similar to what we see in someone with autism: hand clapping, poor eye contact. Again, the hyperactivity. There may be some delay with their motor skills. They're usually very large people.
For muscle tone as well.
Long face. So as people with Fragile X syndrome age, what are some of the things that we would be looking for, Linda?
Balance problems due to ataxia. As you age, those balance problems can become more pronounced. The poor muscle tone also contributes to balance problems. Increased neurological problems such as seizures are common in Fragile X. Poor muscle tone also can lead to some obesity problems, cardiac issues, hypertension. Medications play a huge role in how the person ages, and because of the medications for behavior and seizures that are used with someone with Fragile X, those medications have risks and benefits to them. Some of the side effects of those medications make changes that poorly impact aging.
Okay. Another disability that's common with people with IDDD is cerebral palsy, and this is a non-progressive neurodevelopmental disorder. What that means is it's not going to get worse over time. Usually the neurodevelopmental disorder or damage occurs very early in life at birth. It's commonly a birth injury.
Or a lack of oxygen at birth.
It could also be related to an injury if a child falls, a baby rolls up the changing table, for example. That may also result in an injury that could lead to cerebral palsy. And it persists through adulthood. We're seeing more and more people with cerebral palsy now because infants with low birth weight and infants who do have like anoxia or low oxygen at birth are surviving longer because we have better medical techniques now. People with cerebral palsy may not have any intellectual disability at all. They're often very bright, and they're often able to live very productive lives. However, they do suffer from aging issues that are related to the fact that they're immobile frequently, and Linda's going to talk a little more about that in the next slide.
Chronic immobility results in an increased musculoskeletal problem. You have decreased bone health, you have an increased fracture rate, you have an increased incidence of arthritis or contractures. Ambulation challenges follow someone with CP throughout their lives. And as you age, your muscle tone is changing, you fatigue more easily, so those ambulation difficulties become more difficult because you don't have that stamina and that ability to handle the gait difficulties. You can also have some spasticity and movement disorders. You have that, and with that impaired muscle function, your body is deteriorating. Some people with cerebral palsy, not only are they prone to gait changes and higher fracture rates, they also may lose some of their independence, their ability to walk. They may end up in a wheelchair, whereas prior to that they were able to ambulate. But now their age and their muscle function has diminished, so ambulation becomes a bigger problem.
So people with autism spectrum disorder generally struggle socially. It's a disorder that usually appears in the first 3 years of life. Typically when a child would normally be socializing more, would be developing language and so forth. They often have communication deficits. On the other hand, they have a wide range of abilities. Many people who are on the autism spectrum have no intellectual disability at all, but they do, as I said, struggle with normal social and communication skills. They're also very hypersensitive to neurological input. They may become very hyperactive if they're in a room with a lot of fluorescent lights, for example, or a lot of sort of ambient noise. It may be, something that they hear much more profoundly than somebody who does not have autism. We don't really know what the cause of autism is. There's a great deal of research going on. It is noted that that there's an increase in autism with people who have Fragile X.
Aging with autism, the skills with aging are unpredictable in someone with autism. Many age as anyone else, and others do not. There's an increased risk of seizures in autism. There's also an increased risk of aspiration pneumonias or injuries, accidental deaths, drowning, suffocation, because these are people with poor self-preservation skills, poor communication skills. So they would be more prone to, recently there was a young boy in an elementary school here that wandered out of the school. He had autism. He was nonverbal. He was unable to self-preserve, and he was found several weeks later in the river. He had drowned. These are things that can happen. They need to have enough supervision so things don't happen. They have ritualistic behaviors, may become less frequent with age, but sometimes they don't. It varies. The people with autism that have the higher communication skills tend to fare better through adulthood as compared to someone who has poor communication skills or self-preservation skills. Early interventions with someone with autism in speech therapy, occupational therapy, physical therapy, all can help improve the lifespan and successful aging.
So in general, as Linda was saying, there are no specific aging issues that are associated with people with autism at this time. And I say at this time because most of the research that's been done on people with autism has been done on young children and young adults. I will note that people with autism tend to have a difficult time adjusting to changes. They have a certain inflexibility in the way they approach life. The ritualistic behaviors that Linda was speaking about are a way of comforting themselves, of making themselves feel that the environment is something safe and secure for them. So if they have to change their living situation, if a caregiver retires or passes away, it may be more difficult for them than it would be for somebody who wasn't struggling with some of the effects of autism.
Okay, seizure disorders is another area we're going to look at. A seizure occurs when the electrical system of the brain malfunctions. Uncontrolled discharge of electrical energy in the brain can result in unconsciousness or muscle contractions. The type depends on part and how much of the brain is involved in the electrical disturbance. Some of the seizures we look at are absent seizures, which used to be referred to as petit mal seizures. It's a brief loss of consciousness. Staring into space, possibly, is how you would view. Tonic-clonic seizures is what we used to refer to as a grand mal seizure. Tonic movement being the rigidity, the tightening of the stiffening of the muscles, and clonic phase is a rhythmic muscle movement. There are also partial, simple, and complex seizures. Partial seizures are from one focal point or one hemisphere of the brain, whereas a complex seizure could be multifocal. You can have a loss of function with the seizure, possibly even an incontinence with the seizure. We had a patient in our care, Terry Jean, you recall Terry Jean, and we had a very difficult time getting seizures managed. She either had too many side effects from the meds or she had very poor seizure control. And her greatest wish in life is to not have to wear the helmet that was protecting her from falling because she had no aura, and she would just all of a sudden be on the ground. And to avoid a head injury, we had to use a helmet to protect her. And this was like her greatest wish. So we did try we set her up as a candidate for a VNS device, which is a vagal nerve stimulator. It's similar to a pacemaker. It's an implanted device that when a seizure starts to occur, it sends out an electrical impulse that interrupts it and, in theory, would stop those seizures. We also didn't have tremendous success with the VNS device with Terry Jean because her seizures were so multifocal. They came from so many different areas of the brain. It was very difficult to control her. So unfortunately, we were never able to get her. Her greatest wish was to be able to look pretty and not have a helmet.
But you know, I think what I always like about what you did with Terry Jean is that Linda really took a person-centered approach to working with Terry Jean. I mean, this was a young woman. She was very attractive. She felt very stigmatized by the helmet, and Linda did a lot of research. She contacted a doctor who was actually doing some of the cutting-edge work with the VNS stimulators, and had a conversation with him, had him meet Terry Jean, and had all of the, she really involved Terry Jean in this process. And of course, Terry Jean was really thrilled at the thought that her seizures may be so well controlled that she wouldn't have to wear the helmet. And this would have also made a big difference in her life because she would have had a lot more independence. She had to live a very protected life because, as Linda said, she could drop down on a sidewalk and begin seizing and need immediate emergency room intervention because her seizures also, as I recall, they didn't stop on their own. She was often in status epilepsy.
Yes, she was.
So it's just like kind of a little foreshadowing for later on in this presentation when we're going to be talking more about person-centered planning and really taking a very individualized approach to working with each one of the people in your care. So seizure activity over the years does take its toll on people, and that has an effect on aging. Each time a person has a seizure, it causes some brain damage. Not always a lot, but it does cause some. And if somebody has uncontrolled seizures, as Terry Jean did, where they're frequently seizing, as they age, it's going to affect their cognitive abilities. The other thing that becomes a real problem for people with seizures is that if they fall during a seizure, they often have fractures. And again, as people age, repeated fractures, repeated injuries to their skeletal system begins to have an effect overall. The other thing that's a huge problem with people with seizure disorders is that there are long-term side effects with the use of anti-epileptic medications. And in working with somebody with a seizure disorder, and I think, Linda, this is part of why you were so proactive with Terry Jean in getting the VNS stimulator, is you have to really weigh the risk associated with that medication against the benefits. Of course, you want to prevent seizures and manage seizures as much as possible, but you have to also consider the serious implications that go along with taking an anti-epileptic medication
For the long term.
For the long term, for many years. So some of the things that the anti-epileptic medications can affect are absorption and metabolism. It affects the absorption of cholesterol, folate, glucose. Some of you who are already working with people who have seizure disorders may notice that people using an AED or an anti-epileptic medication have issues with their oral health. It affects their gums. They're very prone to gum disease. It also, another effect with aging is that people with seizure disorders are often, they often need to be inactive, and there's risk of vascular disease that's associated with this inactivity. And again, as I mentioned earlier, frequent falls will really impact the person's skeletal system as he or she ages.
Another syndrome we're going to look at is the Prader-Willi Syndrome, which is an abnormality on the 15th chromosome. Most common life-threatening genetic cause of obesity in children if the obesity is not controlled. PWS typically causes low muscle tone, a short stature, incomplete sexual development, chronic feeling of hunger, which is called hyperphagia, and a slow metabolism leading to that obesity. Intellect range tends to be in the borderline range to mild level of ID. There are motor development delays, small hands and feet. Many have behavior and psychiatric disorders in combination with Prader-Willi. We had a young woman that we were considering to take into one of our homes that was hospitalized prior to our accepting her. And what people in the hospital failed to realize is she had Prader-Willi Syndrome. They had her in a room right across from the nurse's station where the Ensure was stored. Quite a number of cases of that Ensure were there. With Prader-Willi Syndrome, not only do you have that hyperphagia, because you don't have that trigger in your brain to say, I'm now full. So you have this excessive hunger that doesn't seem to ever get satisfied. But she also had no gag reflex. And she was able to get herself into that nurse's station and consume all the cases of Ensure until she ruptured her abdomen, her stomach, and her duodenum. And in essence, they could not save her.
So she passed away.
She passed away in the hospital before we even got her into our program. After that time, we started doing a lot more community training on Prader-Willi Syndrome and the kinds of things you would see with Prader-Willi Syndrome to ensure that those kinds of episodes don't happen, that hospitals are aware of what's involved in the syndrome and the fact that they can be manipulative. They can pursue, they see that food sitting there, and she was going to pursue that because it was there to pursue. And she had that desire that was not being satisfied.
I think that also really speaks to one of the points that we want to be making is that, if you're working specifically with a group of people who have Prader-Willi or one of the other developmental disabilities, you're going to be aware of these things. But community healthcare providers may not be aware of them because they're so specific and unique. And I know, Linda, you've done a lot of education around Prader-Willi, and I think it's really important in developing your system of healthcare providers to include that educational component about specific individuals and what they're struggling with because of their genetics.
Some of the aging things that you would look at in Prader-Willi Syndrome are not that different than the general public. The biggest factor is if morbid obesity existed throughout their lifetime, then they become at risk for diabetes, hypertension, joint and lung problems. If you're able to maintain someone in a controlled environment where they don't have the morbid obesity problems, then you can prevent a lot of those things from happening. Premature aging, like I said, is related to physical morbidity and functional decline and the absolute morbid obesity. If that is controlled, you're limiting the possibility of so many other medical problems occurring. Weight being poorly controlled also can contribute to knee and hip problems. Many end up requiring a joint replacement because they've had uncontrolled obesity for such a long time till they got into a program and it was recognized. And the other part with Prader-Willi Syndrome that contributes to weight is parents will see this child that in the beginning looks like they're failing to thrive, they're not eating well, and all of a sudden change happens and they start to have this huge appetite and they're eating well, and it's initially viewed as, well, my child's gotten better. They're now able to eat and they're doing well, and they don't realize that what they have not been diagnosed with is Prader-Willi Syndrome, and morbid obesity starts to become a problem until they're in a more controlled setting. There is also a higher incidence of cardiac problems also connected to the weight, also specifically right-sided heart disabilities, higher incidence of skin disorders, rashes, dry skin. And a lot of your problems, if they're controlled early in life with the obesity, a lot of those normal aging will occur. Otherwise, you're going to be dealing with the excessive problems of age.
So, are there any questions so far?
No questions.
I think we're going to take a break at this point, about 5 minutes, 10 minutes. So we're going to start again at 2 o'clock, and we'll see you then. I think, Lisa, is it possible for people to type in questions at this point during the break? So if you have questions, please go ahead and type them in. We're happy to answer them to the best of our ability. Thank you.
we're back, and we did have a question from Jackie that Linda and Jill will try to answer now.
Hi, the question is, what they're referring to is the atlantal axial subluxation or cervical instability, which is a problem in some people with Downs. Not everyone, just because you have Downs, has that subluxation. That's why there's a pre-screening done for it, and yes, you would have to pre-screen before your Special Olympics to make sure that that person did not have the subluxation problem, because if they did, then their activities would be more limited. Biking would not be okay. Walking, yes, okay.
Horseback riding?
Yeah, horseback riding, definitely no.
So basically anything where the person has a risk of falling
Right.
would not be good. But if they don't have
If they don't have subluxation, then by all means they're appropriate for the Special Olympics. But you want to know that. You want to have a documented cervical x-ray to note that there is no subluxation before the Olympic activity. And once you have a documented x-ray, if it's negative, then that person does not have that. Then they're just going through their normal, regular exams. If the beginnings of subluxation are noted, then you're doing an annual exam to follow it, just to make that a little clearer.
And, you know, even though some people don't have it, some people do, and in our experience, it has gone undiagnosed. Linda and I actually established a protocol at the agency where we work so that everybody with Down syndrome needed to be evaluated for that atlanto-axial subluxation, because many of the healthcare providers they saw in the community weren't aware of that as a common risk with people with Down syndrome. And unfortunately, one of the people that I worked with had it. It was undiagnosed. She had a virus or a urinary tract infection, so she was really feeling under the weather, and she sat down really hard on the floor, and she just, I guess she...
2 days later, she was paralyzed.
She was. So it was like
the subluxing was there.
The subluxing was there, and that's like you were saying, it's like a tunneling into the spinal column.
Yeah, it subluxes into the next vertebrae.
So, the other thing I want to say is, you know, as we go forward, please go ahead and type in questions if you have any. They can be on what we're currently talking about. They can be about earlier things that we've covered. And Lisa's just recording them as you go, so don't hesitate to ask questions. And we're happy to answer them to the best of our abilities. We don't know everything, but we'll try our best to give you the right answer. Okay, we're going to talk now about the long-term effects of medications and their side effects. So as I was mentioning before the break, when somebody is prescribed a medication, you need to really consider if that medication is appropriate. And you do that by considering the risks versus the benefits. It's important to be aware that when you're treating a lifelong disability or the effects of a lifelong disability, the person may be on a medication for a long time, and that is going to lead to side effects over the long haul. So it's not like taking an antibiotic for 10 days. Sometimes people are on the same medication for many years, and the side effects begin to have a cumulative effect on their health. And particularly as they age, it may lead to deterioration of their physical status, of their cognitive status. So you need to be, as healthcare providers yourselves, you need to be aware of what the person is on and to work together, counselors with nurses, social workers with nurses, to really make the best choices for the people that you're working with. We're going to go over some of the medications that are commonly prescribed for people who have intellectual and developmental disabilities. And you're probably very familiar with these: anti-psychotic medications, anti-epileptic medications, which we're calling AEDs, anti-anxiety medications, anxiolytics. This is why I work with Linda, because someday I'm going to grow up to be a nurse, but I'm not there yet, and hypnotics.
Okay, so first, I'd like to say what are antipsychotics? They're a class of meds used to treat psychosis and other mental or emotional conditions. They block the release of dopamine in the brain. They are several categories, typical being conventional or old generation psychotropics, atypical being new generation psychotropics. Typical are not selective and also block receptors in other areas of the brain, which may produce unwanted side effects. Atypical cause fewer acute or chronic extrapyramidal symptoms. Atypical antipsychotics result in an improvement in mood and cognition compared to the typical antipsychotics. Antipsychotics became more prevalent in the 1950s and have evolved since, and we're going to go look at some of the complications of them. Typical antipsychotic side effects. First, let's explain what the extrapyramidal symptoms are, which is referred to as EPS. It's acute dystonia, which is muscle spasms of the eyes, the neck, and the tongue. Akathisia, which is an inability to remain motionless, or akinesia, which is an inability to initiate movement. Tardive dyskinesia, which is a more serious side effect, is involuntary movements of the face, lips, torso, and legs. Some additional side effects that are common are Parkinsonian-like symptoms, depressed mood, low white blood count, high prolactin levels, seizures may be a side effect, impotence may be a side effect, weight gain, dry mouth, a rapid heart rate, or a very life-threatening problem is known as the Neuroleptic Malignant Syndrome, NMS, which is an autonomic system instability. It's a gradual, it's a loss, you start to lose levels of consciousness to coma, leading to coma and death.
So would somebody with an intellectual or a developmental disability be likely to report these to someone?
Very unlikely that they're going to realize that what they have is a problem unless they're at an upper end of intellectual disability, where they would notice some of the symptoms, or at least the GI symptoms would be a complaint. But we as professionals have to be aware of what you're looking at in symptoms. What is this person normally like, and what are we seeing in symptoms? You need to recognize the difference between med-induced movement disorders. The extrapyramidal system is the voluntary movement system of the central nervous system. It regulates muscle tone, posture, body movement. Extrapyramidal symptoms, side effects of the meds, EPS side effects of the meds would include tremors, dystonias, muscle contractions. Akinesia is reduced muscle movement, and the akathisia is this restlessness. And it's not just a pacing restlessness, it's a restlessness where the person feels like they need to crawl out of their skin, or they're excessively moving their, they feel like they've got to rip up paper or pace rapidly back and forth because they have this excessive restlessness that's not a normal pacing or walking. They also result in dopamine blockage from the typical antipsychotics, that particular group, and treatment with anticholinergic drugs such as cogentin or Benadryl.
So in other words, if somebody had that, that feeling that they were clawing at themselves or they had to rip up paper, you might think it was a behavior issue.
But it's actually a side effect of the med. So when you see a symptom, always assume it's the medicine. Don't assume it's anything but the medicine. First check the medicine. Then if it's not the medicine, go on to look for another medical reason.
So if somebody, say a counselor noticed this behavior in someone, would they refer to their regular physician or a psychiatrist? How would you rule that out?
You would refer it to at least start with a nurse, and have that nurse then refer, that nurse would then refer to a physician. Probably a visit to the psychiatrist who was ordering the psychotropic would be the next best choice. Okay, I'm going to explain a little about tardive dyskinesia, the syndrome of symptoms characterized with bizarre facial and tongue movements, stiff neck, difficulty swallowing. It's a result of a dopamine blockage of a typical antipsychotic. The treatment is to discontinue that antipsychotic, and tardive dyskinesia usually is not reversible.
And I think this is something that we used to see a lot, probably 15, 20 years ago.
When you're using more of the older generation psychotropic meds. I guess I've been told to move over. What we would do to monitor for tardive dyskinesia or for extrapyramidal symptoms is an AIM scale. An AIM scale should be done every 3 months, so when you're paying going for that visit to the psychiatrist that's ordering the psychotropic med, he's going to do a test called an AIM scale. That's, I believe we have a copy. Everybody got a copy of this? Okay. If you pull up the AIM scale, which is Abnormal Involuntary Movement Scale, the record, it records the occurrence of possible tardive dyskinesia in people receiving psychotropic meds or neuroleptic meds. The test is used to detect TD and monitor severity over time. AIMS is a global rating method used to observe and rate movement disturbances. And if you look at the handout, you'll see exactly what we will be looking for is the facial oral movements. There's a scale. And if this is done every 3 months, you have that track record of what is there a change occurring. You're looking at facial movements, lip movements, tongue movements, jaw clenching, extremity movements, your upper arms, the legs. You're going to look to see if there's purposeless movements, or you would see what they call a pill roll. You would someone would be, I don't know, can they see me? You would be the person would be sitting there repeatedly doing the same action. That's a sign of tardive dyskinesia. It's called the pill roll symptom. These are all things that you're going to note on that scale. You're going to look for trunk movements, for neck, shoulder, and hip movements, for rocking or twisting or squirming. Global judgment section, you're going to look for the severity of abnormal movements overall, and you're going to rate each thing, whether it's none, minimal, mild, moderate, severe, and that you're going to give the person a scoring. You're also going to look at dental status. Does the person have dentures that they're wearing? Are they moving all around in their mouth? This could be an indication that there's something wrong. Besides just the dentures aren't fitting properly. It's the excessive mouth movements that are making them move. Do movements disappear when the person is sleeping would be another thing you would ask if that person is able to give you that information, or their caretaker. And then you would score a total score of items 1 to 7. They represent observed movements. Item 8 can be used as an overall severity index. Item 9, incapacitation, and 10, awareness is what you're looking at. Item number 11 is your dental status.
So now, who would normally complete the AIM scale?
The psychiatrist is going to complete the AIM scale, and it's done on a 3-month basis, like I said.
And so for somebody who wasn't a psychiatrist but maybe saw the person every week or even every day, it would be important to be aware of the areas that are going to be evaluated.
Right, right.
So that, you could bring those maybe to the attention of the psychiatrist during the visit, that you've observed those during your time with the individual.
Right. You're going to, you're going to examine that individual prior to going to the psych consult. And you're going to have all that documented. If you're seeing any of this, you're going to have it documented. Because if you have a person that you're taking for a psychiatric consultation for psychotropic medications, they may not, if they can't speak for themselves, you're their advocate. You're the one that's going to be helping that person be treated in the way they need to be. If that med needs to be withdrawn or a different med tried, this is how you would assess that.
And again, as you said earlier, these are symptoms that the person themselves may not recognize as being something important. They may not bring that to your attention. That may be something that
they may not be capable of telling you something's not right. The symptom you may see is simply that they're not comfortable. That's all they're recognizing, that they're not comfortable. But all these little things that you can observe should be recorded and brought to the attention of the psychiatrist prescribing the medication. Now, the next movement disorder that we're going to look at is Neuroleptic Malignant Syndrome. This is a very serious syndrome referred to as NMS. It can be fatal. It is very rare, but it is extremely life-threatening. The symptoms would be fever, Parkinsonian muscle rigidity, tachycardia meaning a rapid pulse, a fluctuating blood pressure, diaphoresis meaning sweating, a rapid deterioration of mental status. I mean, very rapid deterioration all the way to coma. It's caused by typical anti-psychotics, and the only treatment for it is to immediately discontinue that psychotropic med.
Just looking at this, Linda, it looks like this could also be the symptoms of the flu. So it kind of goes back to what you were saying, that you always need to be aware of the medications people are on.
Right.
And consider ruling those out.
Right. Okay, additional movement disorders. The other symptom we look for is anticholinergic side effects of these meds, which is dry mouth, blurred vision, possible constipation, urine retention, any confusion, tachycardia, again being the rapid pulse. These are caused by an acetylcholine blockage, and the treatment is to discontinue any anticholinergic med, which would be your Cogentin, Benadryl, whatever you were using as an anticholinergic med. Some people just can't tolerate them. Okay.
So the typical older generation psychotropic medications, which I guess are the ones that typically cause these movement disorders that you were just talking about, are Haldol, Thorazine, Mellaril. I think that's almost never prescribed anymore.
Right. A lot of these aren't prescribed anymore, but they may be things that people have been on for a long period of time before the atypical psychotropics came into existence.
Prolixin, Stelazine, Novain, Mobane. And with these, as Linda was saying, you're going to see a higher incidence of the extrapyramidal symptom and tardive dyskinesia.
Okay, next.
Okay, now there's a newer generation of antipsychotic medications, and these will probably seem more familiar to you. They're Clozaril, Zyprexa, Seroquel, Abilify, Geodon, and Risperdal. And I guess these have like much fewer side effects, but
they also, everything still has side effects. Nothing has come along that's going to be totally side effect free. The atypicals, like I said, they're the meds that you're probably going to see more of now because there's a tendency not to use the typicals as much. The side effects on atypicals tend to be more cardiac issues, arrhythmias. You have a predisposition to arrhythmias. The benefit of them is less likely to get EPS or TD, but now you're monitoring for arrhythmias. DVTs, deep vein thrombosis, an increase of the risk of aspiration pneumonia, swallowing issues concurrent with both age, meds, and IDDD. So what is it from? But the risk is there. Elevated blood sugar levels, so you need to monitor your blood sugar levels. You may have to back up on the atypical psychotropic you're using, or you may end up needing to treat with diabetic meds to control the blood sugar level. There's an increased risk of a CVA stroke or a pulmonary embolism from these meds, and an increased fall risk because of sedation that comes along with some of the atypicals. Okay, monitoring for atypical antipsychotics. We're going to also still do the AIM scale because you still have that possibility of EPS or TD, so you're definitely going to still do an AIM scale. Even though it is less likely, it's still possible, so you want to know that. You're going to do EKGs because, again, like I said, cardiac arrhythmias is a big problem. EKG is where you're going to pick that up. CBCs for any changes in white cell counts, lipid and liver function tests. Monitor that person's weight. We generally like to take a blood pressure and a weight prior to the psych visit when we're monitoring for a med, so at least we know where we stand. If this person is making a lot of weight gains, then maybe you want to back off on the med, to some degree. Fasting glucose to monitor for those glucose levels may be in order. Monitor for NMS. It's still a possibility. Seizures are still a possibility.
So as people age, the way they tolerate these medications is going to change. Some of the age-related changes are that they absorb them differently, particularly a change in liver metabolism. So you're going to need to monitor for changed liver function tests. They may be less able to excrete the medications through their kidneys. So there's, as the slide says, reduced renal excretion. Other risks include orthostatic hypotension. When the person stands up, they may get a little woozy because their blood pressure doesn't come up as quickly as it should. That's going to contribute to possibility of falls, which in turn increase risks of fractures. And I guess this also affects calcium absorption, and there's an increased risk of osteoporosis associated with it. The combination of polypharmacy, where you're trying to treat a number of different conditions, it has the effect of piling on the side effects. So as people get older, the side effects become more dramatic, and they may be taking more meds because as they get older, they have more conditions. So it's something to really remain aware of and to really always keep in your, in the topmost part of your mind when you're working with someone. So this is the medication I can't say, oxyolytics.
Anxiolytics.
Anxiolytics. I call them anti-anxiety medications. Just saying it makes me anxious. And you probably are quite familiar with these. They're prescribed pretty often and often used like before a med appointment for someone. Xanax, Ativan, Valium, Klonopin, and Restorol.
Some of the risks of anti-anxiety meds in older adults, benzodiazepines, which is the drug category we're referring to, anxiolytic, are typically poor choices for the elderly because of absorption excretion problems as you age. You may need smaller doses. That's a problem that we always seem to have trouble getting across to physicians because you look in the PDR, well, this is the right dose to give for this particular reason why we're prescribing, but what they're not looking at is the age of the person and the absorption excretion issues that go with it. So sometimes much smaller doses have the effect that you want them to have, and that's what you should be aiming for, the smallest dose possible. Increased magnitude of side effects, particularly sedation, memory, and psychomotor impairments. You may have, maybe due to a reduced rate of drug clearance, like I said, in older adults. Some people experience a paradoxical effect, like if you were prescribing to help someone get some sleep or relax, they may end up with excitement and inability to sleep as a side effect of the medicine. That's a paradoxical effect of the medicine. Over-sedation can result in more falls or fractures, so again, you don't want to go beyond what you need to observe and report what you're seeing. Is this person getting too sedated from this medicine? It's time to back off a little. Long-term use may contribute to cognitive decline or possibly even addiction, and then you have to gradually take someone off of a med.
So the next group of medications we're going to talk about are the hypnotic medications. These are often used for insomnia. And again, they're probably familiar to you, Ambien, Lunesta, and Sonata.
And some choices.
There are quite a few of these.
Yeah, there's quite a few. I mean, we're just giving you some of the names of some of the more commonly ones that we see prescribed. Risks of hypnotics. They're not recommended for long-term use. But what do we do with them? We use them long-term. Someone can't sleep, they sort of end up on that Ambien forever. Well, it really was never intended to be used in that way, but it somehow gets used in that way. You also may see that paradoxical reaction. Instead of getting the sleep that you want to get from this medicine, they may end up awake all night. They can be associated with a delirium or an anticholinergic side effect, which we talked about earlier. Additional potential side effects include excessive sedation, a morning hangover from the medication. So you're not getting a normal sleep, you're getting an over-sedated sleep, and then you have residuals of the med that you're waking up with. And an increased risk of falls and fractures.
Okay, we've talked a little bit about the anti-epileptic medications already, but we're going to go over those as well. Depakote, Dilantin, Tegretol, Mysoline, Lamictal, and Neurontin are some of the most commonly prescribed AEDs.
AEDs, like any other medicine, also have benefits and risk. The newer AEDs are better tolerated in the elderly, often causing less sedation and require less monitoring. AEDs are known to increase the risk of suicidal thought, and you need to monitor for that signs of depression. And they need to be prescribed for at least a specific seizure type. Each drug category, each AED you're looking at has different benefits to different types of seizures. So you want to know that you're prescribing in a way that's effective.
So when you're talking about different types of seizure, would that be what you talked about before, tonic-clonic?
Tonic-clonic, petit-mal, atonic, some of the seizure types we're looking at. Is it multifocal? Is it one area of the brain that the seizures are coming from? All those things require taking into consideration what med you want to prescribe. There's also potential adverse effects of AEDs. Some of the adverse unwanted side effects of AEDs are drowsiness, tremors, impaired cognitive skills, Hyponatremia, low sodium counts. You want to monitor sodium levels, especially Tegretol has a great impact on lowering sodium levels. Coordination problems sometimes come along with prescribing AEDs. They may inhibit or stimulate liver metabolism. That's why you're doing liver profile scans, liver function blood tests. You can have gum disease, particularly with Dilantin. So, as Dilantin is kind of an older school AED, but it also seems to be the only one that works for some people. And when you're using Dilantin in the long term, you really have to watch for the gingivitis and the gum overgrowth. Bone loss from long-term therapy is a problem. Serious skin reactions such as epidermal necrolysis, a low white blood count, visual disturbances, agitation are all unwanted effects of AEDs.
What would an epidermal necrolysis be? How would you describe that?
A black discoloration on the skin.
Is that something that is common?
Not common.
But it's still something that you would want to
still, if you saw a skin discoloration, you want to report it. And that drug may have to be withdrawn.
So you want to be observing and monitoring people for any unusual signs and symptoms when they're working with or when they're taking AEDs, and you want to bring it to the attention of the medical professional. Probably, the first person you would talk to about it, if you're not the nurse, would be the nurse. It's important to realize that not only do people with IDDD have physical problems that are associated with their developmental disability, but as they grow older, they're going to have additional issues on top of those. And they may absorb the medication differently, it may be slowed, they may excrete it differently. So you want to also pay attention to the interactions with the other medications that they're on. As I said earlier, somebody who's older may have a variety of different conditions. They may be taking a variety of different meds. And so you can be piling on these medications and these side effects, and you want to really pay attention to changes. And as Linda has been saying throughout this presentation, when you see a change, you want to immediately consider that it could be the result of a medication. Doesn't mean you're supposed to stop the medication. It means you need to refer to one of the medical professionals that you're working with. Other interactions, if a person is taking antacids, for example, it might decrease the absorption of Dilantin. And Dilantin and Tegretol, which are also commonly used AEDs, may reduce the level of Coumadin, which is an anticoagulant. So I was really surprised when we were doing the research for this presentation to find out that 41% of hospitalizations for people over 65 are related to
drug-related hospitalizations.
They're drug-related, are related to their medications, or that account for that. Common medications that people over 65 take are digoxin, which is cardiac medication, insulin, and warfarin.
Warfarin is Coumadin, just so someone.
That's the generic for Coumadin.
Yes.
So these issues are also frequently related to emergency room visits. So medical or side effects associated with medications are things that become much more prominent as somebody ages, and they result in hospital use that might be unnecessary if medications were managed more effectively.
The other thing we wanted to point out is when you bring someone to an emergency room or to a doctor's office, you want to bring the medication list with you, because the doctor that you're visiting may not be the one who prescribes some of the other meds and may not be aware of them. You can't evaluate drug interactions unless you know what all the drugs are. So you want to bring a current list of what medications and what amounts that person is taking on any visit, whether it's the ER or to another physician, because it may not be known from one to the other. Communication always seems to get in the way. And of course, the people that you're working with, people with intellectual and developmental disabilities, may not remember all of the medications they're on, or they may have a communication deficit and be really unable to report the medications that they're on. And if they're ill, if they're experiencing a side effect, that's going to increase anxiety, and that's also going to complicate their ability to self-report. So they're really relying on you to provide the information that can really be, the difference between life and death in situations. So
just to kind of review what we've been talking about, aging makes everyone more prone to side effects. And we can't say this enough. Any symptom in any elderly person should be considered a side effect until it's proven otherwise. And I remember this gentleman who had some kind of event at his home. His family caregiver was not a native English speaker, and in his broken English, he described what had happened as an apparent seizure. He didn't have another. The person was admitted to the hospital. He was elderly. He didn't have another seizure, but that was probably because he was prescribed Tegretol, and he was prescribed Tegretol at a level that was really much too high. And within a couple of days, he went from being this very charming and delightful elderly man, very verbal, someone who was flirtatious and a good joke teller, to someone who was really just lying in bed in the fetal position. And it wasn't that he was aging. It turned out that he was having a very bad side effect from the Tegretol. As soon as the Tegretol was withdrawn and his seizure disorder was managed with another medication, he improved amazingly. So medications that are not used appropriately, effectively, and safely can have devastating consequences, and we really need to keep that in mind. And as we keep reiterating, you need to know your people's baseline. You need to know, like we needed to know that guy, Alfred, was this funny, social, highly communicated man, and that what we were seeing was just completely the opposite of what we were used to knowing with him.
Okay, I'm going to talk a little bit about prevention of medication-related problems, kind of reiterating some of what we already discussed, but just, again, medication side effects directly impact daily functioning of elderly or disabled. Monitor for symptoms such as the lethargy, the confusions, the depression, insomnia, incontinence, loss of appetite, falls, fractures, speech or memory changes. Monitor for a need for new meds. Pain and depression often go undiagnosed and untreated, leading to declines in function and participation in social activities. So like Jill was saying, you have to know the baselines of who that person is, because they may not be able to communicate for themselves. But chart to chart, person to person, staff to staff, family member to family member, someone needs to share who this person's really was, what that person's baseline is. So if you're having a medication side effect, you can pick it up.
And I think another important piece of this is to always remember that the people you're working with, because of their disability, may not experience pain in a typical way. They may not report pain in a typical way. And the same with depression. They may feel really sad, and they may not say, I'm feeling sad, I'm feeling alone. What they may do is become more angry, more agitated, or they may isolate themselves, spend more time alone, and avoid things that used to interest them. So you need to be aware of the changes that you see in the people you're working with, and you need to be very proactive and kind of teasing out from them what's going on so that you can get a complete picture of what that person is experiencing.
Okay, a few more points on prevention of med-related problems. Monitor for the unnecessary meds as medical problems change. People sometimes end up stuck on a med because, oh, well, they always got that, so we should continue it. Well, maybe they don't need it anymore. Those are things that need to be reassessed on a regular basis. Avoid problems from wrong med choices or an inappropriate dose or a condition not responsive to the med, or a more effective med may become available. So it's a constant reevaluating process. Are we using the right things for this person? And are they things they need? Or are they things that interact with another med they're taking, and you need to reevaluate what you're doing? Elderly individuals are more sensitive to CNS, central nervous system side effects of many medications, so you need to be alert for oversedation, agitation, sudden change in mental status.
So with all that being said about medications, you can understand why it would be important to consider other ways to work with people that don't involve a medication. Of course, if it's a seizure disorder or something that needs to be managed with a medication, you're going to use that medication. But with some of the other issues that people confront as they age, you may be able to manage it without using a medication. If somebody, for example, has trouble getting to sleep at night and spends a lot of time being agitated and restless in the evening, consider, decreasing the afternoon caffeine, maybe serving herbal tea instead of a cup of coffee, or decaf if the person likes that. It might be important for the person to get out, get some fresh air, take a walk instead of taking the afternoon nap. You also want to be aware of people who are getting up at night to use the bathroom.
Limit fluids.
So you would limit fluids, but that's also, getting up in the middle of the night, that also is an increase in fall risks, I'm thinking.
Yes, it is.
Many people get up at night and they don't see well, so they may trip, and then, you have another issue. Another issue to consider is nighttime pain. As people age, they may have aches and pains and sore joints. They haven't raised to the level of a diagnosis of arthritis, but there's still something that impacts their ability to sleep. And again, people may not be good self-reporters. Aging comes on gradually and subtly for most of us. So you think, well, today my knee hurts, it's probably going to be better tomorrow. But then when it isn't, you just sort of keep going on. So if you notice that somebody isn't sleeping well, pursue that with them. Find out what it is that's keeping them awake. It could be something as simple as a roommate snoring. And, you could change the room and avoid, prescribing a medication.